Mute on.
Well, good afternoon or good morning to those of you on the West Coast. I'm Andre Gonzalez, AVP of Product Management for our Value-Based Solutions at Change Healthcare, and I'd like to welcome you to today's webinar, which is brought to you as part of the Healthcare Executives Group webinar series to discuss key challenges facing payers and providers as identified in their annual Industry Pulse Study. In this webinar, Lisa Conley of Change Healthcare will share her research into value-based payment strategies, and Brooks Daberman from the state of Tennessee will discuss lessons learned in the state of Tennessee from their introduction of episodes of care and other value-based payment strategies. We encourage you to submit questions throughout the presentation. Please type in your question in the box labeled Q&A and click Submit. We will answer any logistics questions right away, and we'll answer as many questions as possible on today's topic at the end of the presentation. This call is being recorded, and the recording and a copy of today's presentation will be provided in a thank you email that will be sent after the conclusion of the webinar. And now about our presenters today. Lisa Conley, JD, MPH, is a Government Affairs Specialist at Change Healthcare. In this role, Lisa focuses on state and federal regulatory and legislative issues that impact the healthcare industry. Prior to joining Change Healthcare, Lisa spent 10 years in leadership roles in state and city government, including 3 years in the Massachusetts State Legislature. Brooks Daberman is the Director of Healthcare Innovation at the Tennessee Division of TennCare. He is directing the Tennessee Healthcare Innovation Initiative, a project to change how healthcare is paid for in Tennessee, moving from volume-based to value-based payment. The initiative partners include TennCare, Cover Kids, State Employee Benefits Administration, Tennessee's 4 largest insurance carriers, the Tennessee Hospital, the Tennessee Medical Association, and many others. Mr. Daberman has a master's in public policy from Duke University. Now I'd like to hand the call over to Lisa.
Great, thanks so much, Andre. As Andre said, my name is Lisa Conley, and I'm going to take you through the results of the State Value-Based Payment Study in about the next 15-20 minutes. As a reminder, you can access the study at statedbrstudy.com at any time if you're interested in taking a look at the full report. So we're going to cover the following things today. First, just some really quick background on value-based payment and why we think it's important to look at what states are doing in this space. Second, we'll talk about what's driving the reform in the states. And finally, we'll cover the findings of the study and give a few examples of what we've learned. As a quick table setting exercise, I want to talk about value-based payment and what we mean when we use that term for the purposes of this study. For this study, we looked across states to see what each one is doing on value-based payment. So basically, we're looking at any state initiative that attempts to tie quality or value to payment in the healthcare system. If you're familiar with the HCP land document that's on the screen right now, and maybe some of you have even participated in the development of the framework, we're talking about the categories 2, 3, and 4. So basically, all payment arrangements from paying for performance arrangements in category 2 to bundled payments, which fall into category 3, and population-based payments in category 4. They're all counted in this report. Where possible, we make the effort in the report to differentiate between the various categories, but we give states credit for any and all efforts to move towards value-based payment. So why are we studying the states? For years, the federal government has been driving forward policy on value-based reimbursement, but things are beginning to shift in Washington. We're starting to see the federal government step back from its leadership role and to push for more state-level innovation. In August, we saw CMS cancel 2 of its proposed mandatory bundled payment programs and cut a 3rd program in half. In September, CMS announced its New Directions RFI, which explicitly calls out states as an area of focus for the Innovation Center moving forward. Finally, just this past week, CMS announced an initiative to give greater flexibility to states in their Medicaid programs. These are quotes from 3 leaders in Washington taken over the last 6 months, which basically reinforces the previous point. The federal government is focused on states as leaders in the healthcare space, and which is demonstrated in both their rhetoric as well as in their actions. I'd especially like to highlight the quote in the middle from Seema Verma, the CMS administrator. The quote comes from a speech she delivered last week at the annual conference of the National Association of Medical Directors, and her message to that group last week was to convey the sentiment that the relationship between the federal and state government was out of balance and that the federal government had been exercising too much power in the healthcare arena. The intention of the administration, if followed, is to restore the balance by ceding back authority to the states. The implication is that states, because they are more aware of local conditions, will spend the resources more efficiently if left alone. Another reason to focus on states is that states are increasingly in control of a significant amount of our healthcare spend. From this slide, you can see that Medicaid spending alone has increased from $150 billion to $550 billion in the last 20 years. Now, some of this increase can be attributed to increased enrollment, including the Medicaid expansion, but there's also been an increase in per capita Medicaid spending. States are also seeing an increase in costs related to their employees and retirees. So through contracting alone, states are able to use their spending to influence the market to move toward value-based payments. And finally, as I'm sure you're all aware, states have regulatory authority over much of the insurance industry. Some have broader authority than others, and some use the authority they have much more aggressively than others. And some states are beginning to use this regulatory authority to require health plans in their state to adopt value-based payment arrangements. So what's driving the reform? Laws like the Affordable Care Act and MACRA created new opportunities and incentives to move away from fee-for-service and towards value. In addition, the Obama administration, with the leadership of the CMS Innovation Center, put a number of programs in place to encourage states to adopt value-based payment arrangements. Perhaps the most significant program was the State Innovation Models Grants, which were released in 2 rounds in 2013 and 2014 and distributed over $1 billion to 37 states. These grants helped fund both planning and implementation of statewide delivery system and payment reforms. Finally, it's important to emphasize the reality that many state legislatures and governors face as both employers and administrators of their state Medicaid programs. Costs are going up for them as they are for everyone else, and the cost of healthcare is second only to education as a portion of state budgets across the country. So now is a really good time to get engaged on the issue of value-based payment if you're a state. Now, to dive into the results of the study, we found on balance that most states were doing something to push away from fee-for-service and move toward value. You see that in about 40 out of 50 states, there's at least some activity in value-based payment. However, we concluded that only a small number of states are actually leading the way on value-based payment. About a quarter of states have invested in strategies that go beyond their state-funded programs, like Medicaid and state employee insurance plans, to include commercial plans that operate in their states. Finally, almost half of the states have followed the lead of the federal government in setting targets for value-based payment. We'll talk about this more later, but this strategy varies significantly across states and can involve either voluntary or required adoption of value-based payment models in a given state. This map shows the widespread nature of value-based payment initiatives across the U.S. And I want to be clear that even though this map is colored in with red and blue, you can see that this phenomenon is really not a red state, blue state issue. We see states with Republican governors that have very comprehensive value-based payment programs and states with comparable investments from Democrats. The deep blue states in this map indicate a robust adoption of value-based payment by the state government. In general, the states in this category have a plan in place and have been executing on that plan for a number of years. We are fortunate to have one of these advanced states, Tennessee, with us on the webinar today. The red states are the ones we've termed evolving. They typically have a plan to move forward on value-based payment, but have fewer than 2 years in implementation. The gray states are those that made the cut by doing relatively few things, but haven't fully committed to a vision of value-based payment transformation in their states, or maybe are just in the very beginning stages of implementation. Finally, the white states on the map are those that show very little, if any, evidence of adopting a value-based payment strategy. That's not to say that other actors, including commercial plans or the federal government, aren't doing anything to further value-based payment in those states. It simply means that the state government does not appear to be very invested in it. So this slide just gives a little bit more detail about how we categorize the progress of states' value-based payment initiatives. In general, we looked at 2 factors. First, duration. That is, how long has the state been in implementation phase? of their initiative. And second, we looked at complexity. How sophisticated is the strategy? Are states pushing toward alternative payment arrangements, that is categories 3 or 4, that require providers to accept downside risk? And is the initiative multi-payer? Here we see that there are only a few states leading the bubble, but a bunch of states in the middle two bubbles that are either early in implementation or have programs that are less complex. For example, maybe they focus exclusively on Medicaid reform or a subset of the Medicaid population, or maybe they are still in category 2 payment arrangements for the most part. And those in the bottom bubble are the ones that have done nothing or next to nothing to move towards value-based payment in their states. What I will say in general about this slide and the one before it is that our categorization should be taken as a best guess about where everyone is on the spectrum between fee-for-service only and varying degrees of value-based payment. You could make arguments to move states in the middle bubbles either higher or lower in the categories, but what's important is that we have a handful at the top and a handful at the bottom, and for the most part, a lot of states are actually trying. So what are the key strategies that states are using to transition to value? We identified a number of similar strategies that states employ when encouraging their insurance market to move toward value. One of the most prevalent is the strategy to adopt mandatory or voluntary targets that require health plans to tie payment of providers to value. In basic terms, this strategy allows the individual health plans to decide which type of value-based payment arrangement to adopt and to negotiate the terms with their providers. The second option that is common is this patient-centered medical homes, which are especially popular in state Medicaid programs. These arrangements typically involve making an extra per patient per month payment to primary care providers to engage in care coordination, as well as additional payments if certain quality measures are achieved. Other states have chosen to tackle value-based payment by encouraging adoption of an ACO model. Basically, states encourage providers to align into ACOs and pay them a capitated risk-adjusted monthly payment to provide all care that a patient may need. Finally, some states have adopted an approach that uses episodes of care or bundled payments to pay for care. Episodes typically involve a shared savings or shared savings and risk arrangement between the payer and provider. As we noted on the last slide, about half the states in the U.S. have set a target to encourage state-contracted health plans or regulated health plans to adopt value-based payment. In this slide, the blue states are those that have a multi-payer target set in their state that cuts across all health plans in the state. An example of this strategy is the state of Rhode Island, which has passed a regulation that requires all state-regulated health plans to take steps to ensure that 40% of insured medical payments made in 2017 are made through an alternative payment methodology. This percentage ratchets up to 50% of all payments in 2018. The gray states are those that have set targets for value-based payment adoption in their contracts with Medicaid managed care organizations or are planning to do so in the next year. An example of this strategy is the state of New Mexico, which requires its MCOs to have 16% of payments in 2017 tied to value and to step up to more complex payment arrangements in later years. As I noted earlier, ACOs are a popular model for states to choose when adopting value-based payment arrangements with providers. At least 15 states, according to our study, have adopted the ACO as a strategy, with payment types ranging from pay for performance to shared savings to fully capitated shared savings and risk. One example of this from the West is Oregon, which has established regional coordinated care organizations that provide mental, physical, and dental care to their member populations for a risk-adjusted per-member, per-month payment. Similarly, in the East, Vermont launched an all-payer ACO program which allows all commercial and government payers to align around a per-member, per-month payment to ACOs for care provided to attributed members. Finally, we noted that episodes of care or bundled payments are also a popular model for states to adopt. There are 3 states, including Tennessee, which have adopted episodes of care as a strategy to move toward value-based payment. We have a great example of this model on the webinar today, but I will note that both Arkansas and Ohio have also taken this approach. In addition to these states, several others are considering a bundled payment program in the near future, as indicated in the gray shading. So just to recap before I hand it off to Brooks, our study found that there is some exciting innovation happening at the state level in value-based payment. Many states are embracing these strategies and using it as an opportunity to engage with stakeholders in their healthcare systems to improve care and outcomes while saving valuable healthcare resources. As with any study, this one has its limitations, which mainly stem from the way the data was collected. We collected the data presented in the report from publicly available sources, but we're not able to verify all of the state websites to ensure that the information was still current. The other thing to remember is that administrations change, and so as new governors take office, you may see shifts in strategy. With all of that said, I'm now going to pass the presentation off to Brooks to talk about the great work that he and his team are doing in the state of Tennessee.
All right, well, thank you, Lisa. Hi, everybody. I'm Brooks Berman. I'm the Director of Strategic Planning and Innovation at TennCare. I want to thank Change Healthcare for highlighting the work that is going on in states to move to value-based payment. That's obviously a topic that's near and dear to my heart, and I've certainly spent a lot of time on some of the same websites that I think that they have to find all this information. It's great to have it all in one place. And I'd also like to thank Change Healthcare for inviting me to be a part of this conversation today. So in Tennessee, we set a bold vision for being a leader in reforming healthcare. If you can remember, at the time everyone was talking, when this came out, it was about 2013, everyone was talking about the Affordable Care Act, but some people were saying that we really need to get to the drivers of cost and quality in healthcare, or else these debates about who gets coverage just get more and more difficult, which actually sounds very familiar to the national conversation we're having now. So we set out to deal with a majority of healthcare spending and all the different areas of a very diverse industry. We heard from providers that alignment was very important. They wanted to know that they could deliver the same high-quality care for patients, whether they were insured by one company or another, and be rewarded for it. So we took that to heart, and we had a significant investment of time from many stakeholders, including hospitals, doctors, insurance companies, and employers, and we sincerely appreciate how they worked with us to make our strategies the best they can be. And so this slide, I wanted to show you all what it looks like to be in a state that's trying to comprehensively move to value-based payment. It is the work of years. We have been at this for over 4 years, and some aspects of what we are doing have taken years to come to fruition. We've counted how many meetings we've had. We've had over 1,200 meetings with stakeholders on this initiative, and you can see how that breaks down over the years. I'll mention there's only about 260 working days in a year, so you can see some years we're having more than one meeting a day. And I'm not counting our internal state meetings. I'm not counting communication between an insurance carrier and a provider one-on-one to explain this. So anyway, a lot of meetings. Procurements and partnerships, we do a lot of these. This is how states get a lot of work done, whether it's consultants to work on design, or stakeholder processes, trainers, or technology. Each procurement is a 6-month minimum process for a state. Partnerships are a little bit faster to get started. And then finally, we get to some milestones. Our first episodes report went out in 2014. PCMH and HealthLink started in 2017. We just got started on quality apps, which is our way of collecting non-claims-based quality data when we need it, when it's not available in claims. So anyway, the point here is that making a big change in a state requires a lot of work over years. So the next slide is our 3 strategies. These strategies combine to comprehensively address most areas of healthcare, most types of healthcare professions, and most types of patients. We are holding providers accountable for not just the services they provide, but for all the related services the patient receives. There are areas in each of our strategies where the patient's behavior plays a role. There are areas in each of our approaches where providers are being held accountable for what a different provider did. So we're moving beyond just what a provider directly controls and what a provider and moving to what a provider can influence. And for each strategy, we are making sure that providers have new information available to help them be successful with the new strategies. So in primary care, we are paying for preventive services and maintaining a person's health over time. We have also developed a program called HealthLink for care coordination services for our members, our TennCare members, Medicaid members, with the highest behavioral health needs. Our episodes of care strategy focuses on acute or specialist-driven health care. We reward providers who deliver cost-effective, quality care associated with a specific health care event, such as total joint replacement or a heart procedure, for some examples, and we penalize providers who are the most expensive in the state. Episodes is a big strategy in Tennessee. We have more episodes in place than any other state. And these are mandatory payment approaches. So if you're an OBGYN in Tennessee being paid by Medicaid for delivering a baby, then you are in the episodes. If you're a hospital being paid by Medicaid for treating a child with an asthma attack, then you're in episodes. And in January, we will be up to 29 episodes in a performance period. So that's a big change. Long-term services and supports is an important area for states. This is nursing home care and home and community-based care, so care from a person who visits the home, the patient at home, for example. Medicaid is the primary payer for this type of care, even for many people over age 65 who have Medicare. It's the state Medicaid who pays for the long-term services. This has been an area where there are not that many forays into value-based care, so I'm proud of what we have done in Tennessee. Okay, so a little bit deeper into primary care transformation. This strategy involves two value-based payment approaches, patient-centered medical home and Tennessee HealthLink. Our TennCare plan, so TennCare is Tennessee Medicaid, have been rolling out patient-centered medical home strategies for many years, but we wanted to take the progress further. We felt that by aligning the approaches across the health plans, it would be easier for the practices to participate. So we're taking the best of each plan and putting them together. There are 29 PCMH organizations covering 250,000 TennCare members right now, and an additional 41 organizations will join in January, which will double the number of members we're covering almost, and will be above 1/3 of members, TennCare members in a PCMH. There's a PM payment. There's a reward to providers who are successful in having lower utilization and meeting quality measures. And then HealthLink is our value-based approach to care coordination for members who have the most significant behavioral health needs. They have schizophrenia, bipolar, a hospitalization for behavioral health, or they've been identified by providers as needing intensive care coordination. We have 21 HealthLink organizations statewide, 64,000 members enrolled, and there's a reward for quality of care and efficiency here as well. But we're not just throwing providers in there. We are giving them new information. We have set up an online care coordination tool, so our PCMH and HealthLink providers can log in securely and see all their patients. They can see who are high priority patients, who are at risk, where are their gaps in care, and we're loading this with claims data and pharmacy data. But the most important element is we've partnered with the hospitals to load admission, discharge, and transfer data feeds. So the most actionable real-time information that you can give to a primary care doctor or behavioral health provider is whether their patients are in the hospital or the emergency room right now. And we have half of hospitals sending in that data. We're on track to have almost all of them probably by the end of this year. So on to episodes. This is the next slide. We have designed the episodes in the first and second column that you see here with a lot of input from expert clinicians in Tennessee. And as I said, we have 29 episodes that will be in a performance period in January. Episodes are for acute and specialist-driven care. Episodes reward hospitals, physicians, rehab facilities, other providers who work across healthcare silos to find better ways to coordinate their services. They reward accountable providers for the services they can control, which are the services they deliver themselves, but also for related services that they influence but don't control. For example, when there's multiple options for medication, which have different costs, or when a provider can have a discussion with the facility about how to improve quality and reduce costs. Episodes are designed to take into account the total cost of care, which includes variation in utilization and prices. Prices are an important part of the overall cost of healthcare to taxpayers, so we thought it was important to address that here. And also, providers some are better than others at reducing inappropriate utilization. For example, some providers are better at tracking and coordinating care transitions for their patients, and that results in better patient outcomes. So episodes have been going for a couple of years, so we can share some results. We saved an estimated $14.5 million in 2016. Perinatal is our biggest episode. For the non-Medicaid folks in the audience who don't know, most Medicaid agencies pay for about half of births in the state, and Tennessee is the same here. We saw a significant decrease in the cost of our perinatal episodes in the first year. It ticked up a little bit in the second year, but we're still, in 2016, we're below our baseline year of 2014. So that's great. I mean, you don't expect healthcare costs to go down in most cases. We're not just bending the trend, we're actually bending it backwards. Asthma exacerbation, another big episode for us, which is asthma hospitalization. It's a hospital episode. The costs have dropped 2 years running. And you can see that we're below our projected trend in almost all the episodes we had in 2016. Non-acute PCI is the only example that went in the other direction. That's a low volume episode, so it can bounce around a bit, but it is definitely something that we'll be watching. And then quality results, we either maintained or improved quality in almost all the categories that we measure for our first 8 episodes that we had in 2016. So you can see improved screening, reduced C-sections. In COPD, we had increased follow-up care, and a lot of the other ones basically stayed within a percentage point, with 1% of where they were previously. Okay, and then long-term services and supports. Remember, this is our third strategy. We have new payments, we have training for provider staff. There's a lot of turnover, and these are folks who do not have as much training. So training is an important aspect of quality. In long-term services, many of the quality of care measures are also quality of life measures. So one big improvement we have seen is that our residents have more choice in their lives around what they eat, when they eat, whether they take a bath or a shower, when they get to go to bed or wake up, and how their room is decorated. These are meaningful to them and are important in their lives. A little bit lower on that slide, you can see Tennessee used to be tied for last in the overutilization of antipsychotics, which is, in a sense, the medical restraint. We had a large reduction here. We're actually in the middle of states now, so that's great to see. And another result on the right-hand side, we changed how we pay for ventilator care to emphasize getting people off of the respirator, which is called weaning. And we've had people coming off their ventilators after being on them, in some cases, for years. And that's just a significant impact in that member's life. So paying to reward getting people off of their respirator has really shown great results. Okay, lessons learned. What have we learned from all this? I have so many things that I've learned. I tried to get a couple of them that I thought you might find interesting. First, as I mentioned, alignment of approaches was an important focus in Tennessee. And providers told us that they would be much more able to make necessary changes if all of the carriers had the same approach. We deliver Medicaid through 3 managed care organizations in Tennessee, so we wanted to at least have all 3 of our managed care organizations using the same approach. And where possible, we wanted the commercial carriers to adopt the same approaches as well. But this can be challenging. The national carriers, they have their own approaches. Sometimes they're very proud of their approaches. They don't want to do something different from their national approach in Tennessee. But we have had success in working with both the managed care organizations and with the commercial carriers in Tennessee. We have an independent Blue Cross in our state, and they are implementing episodes. Cigna is making episodes a big part of their national strategy, and because of the focus on this in Tennessee, they've really started it in Tennessee. We used our state employee population, which is the largest self-funded employer in the state, to jumpstart the commercial market, and that's an approach that I would really recommend. The second lesson learned is that when you are aligning approaches across different managed care organizations and commercial carriers, it involves a lot of discussion. Remember the reference to the number of meetings in order to understand the issues and to get to a compromise. It's hard to talk about these technical details and also keep the CEOs engaged. I found that you really need to have two tracks of meetings, one that's in the weeds and one that's more high level. I will say, and Lisa mentioned this, that there are other states that have just set targets for how much they want each insurance carrier to do in value-based payment without being so prescriptive. Lisa showed you that map of states. There's a lot of value to that approach because each carrier gets to chart their own destiny, they get to make their own investments, but you do lose the alignment. And I think it's harder to be as bold if you don't have the alignment, because there's a tendency for each insurance carrier to be worried about getting too far ahead of the others. So, you know, there's pluses and minuses to both approaches, I guess is what I'd say. Third lesson learned, I don't think this gets enough mention, but what I've seen in Tennessee is that the insurance carriers are just not set up, or they historically have not been set up to communicate a statewide mandatory change to value-based payment. Really, for this, you need an army of people who can understand some complex concepts and to then explain them to doctors and nurses who have a great deal of experience and training and intelligence and ask really good questions. Insurance companies for a long time have tried to pay claims with as little overhead as possible. They do want to have some great negotiators, and that's the model. Their provider outreach staff really needs to increase in size and capability for these types of value-based payment initiatives if they're going to be really comprehensive and large. So we're doing things to make that change in Tennessee, but there's always more we could do here. Okay, number 4, this is a complex industry. Healthcare has many different types of services that are included in that umbrella, and it's complex in the sense that, you know, that every patient is different, every provider is different, and so when you're trying to really target those areas that you want to see changed, but also control for patient variation and random variation, you're faced with a trade-off between a complex approach that really gets at everything and then a simple approach. I'd say for almost every question that we face, it's sort of, okay, do we want to be simple, easy to communicate, and easy to understand, or, you know, do we want to go with the more complex option, which is going to potentially create more fairness, but be harder to communicate? And so, you know, you're constantly making those kinds of decisions. And again, we're making them with all the stakeholders at the same time. And then, you know, number 5, I think that there are a lot of providers who understand that value-based payment is inevitable, that fee-for-service is not working, and they're actually looking forward to it. They see that there is going to be opportunities for them to practice in a way that will be better for their patients, and actually allow them to practice medicine in the way they imagined when they first got their training. If you're involved in a voluntary value-based payment initiative, most of the providers you meet will fit this type of description. And I will say that these days, there are a lot more providers that think this way. But if you're involved in the mandatory approach, you're also going to encounter providers who have always weathered any talk of value-based payment by keeping their heads down and just plugging away at fee-for-service medicine. And so, you know, that's a communications challenge, and, you know, you got to really show them that they are going to be able to be successful in this new world. So another trade-off, another decision that states are making is, you know, which approaches are voluntary, which are mandatory, and this is the kind of trade-off that you've got. But it is possible, and I think Tennessee and other states, and now you've got some maps of some other states that are successful with a comprehensive statewide approach. They're showing results. They are changing the conversation and leading the way to address the enormous challenges we have in our country in figuring out how to improve quality of care and still be able to pay for it. So thank you all for listening. Thanks to Change Healthcare. I'll look forward to any questions and turn it back over.
Well, thank you very much, Lisa and Brooks. Those comments were very insightful, and definitely enjoyed hearing them. We do have a couple questions here. I'd also like to remind the attendees, the audience, that you're welcome to enter any questions in the Q&A section of the WebEx. The first question I have is for Brooks. Brooks, with Medicaid and states taking the lead, will Medicare start to coordinate with the states on the types of programs implemented?
It's a good question. It's impossible to predict, and it's really, it is the decision of the federal government. But I could point to a couple of positive things, I think, in this area. So, one is Seema Verma, who's quoted earlier. She is someone who has been involved for a long time in innovation at the state level and really knows Medicaid. I think that there's been a lot of CMS folks in the past who really started with Medicare. And so it's nice to see that. I mean, I know Seema from, before she took her current position, and, I think that she's a great person to have there. They've certainly indicated an openness to states being laboratories, to taking different approaches and using their waiver authority to facilitate that. And so that's the freedom to the states. The other part is, will Medicare then join in? And obviously Medicare is a big payer in every state, and the Medicare beneficiaries are disproportionate users of health care. I'd say, 8 years ago, Medicare was much more focused on, we're a national payer, we can't do something different in every state, and that theory has really changed to where they recognize that they're going to be doing different things in different states and different approaches. So that's good, and I think it points to, they at least have built up some capability and willingness to do it. So I'm hopeful that they will continue to do more to engage with states.
Okay, thanks. We have a question that came in on the chat. So this question is about, I think, how the industry measures adoption of value-based payments or value-based programs. The comment is that there are a number of statements and claims out in the industry that maybe 30 to 50% of provider payments are under some sort of value-based program, and the commenter finds it hard to believe, that, and what that probably means is that 30 to 50% of their payments have some component of reimbursement based on a quality or value measure, but not 100% of that payment. I could comment on that, but Brooks, I'd be interested in your thoughts on that too.
Yeah, I think, when you do peel away at those numbers, you can quickly see a lot of payments that are, they're sort of in a pretty low level. It's a pay for performance kind of thing. It's not very significant. And so I think that the work of the LAN has been helpful here to kind of pull apart the different flavors. And I'll also plug an organization that Tennessee is a member of called Catalyst for Payment Reform that has done some work around, okay, we've got a lot of value-based payment, but what really works here, and starting to define that and coming up with standards for an accountable care organization, what that really means. So I think that the next level is really to talk about, okay, we've got this much payment in some form of value-based payment, but how much do we have in forms that are really have the potential to make a change or have been proven to work?
Thanks for that. And I would just comment as well that, you know, in our work with both health plans and health systems, what we see is that the fee-for-service infrastructure is usually still intact in these programs. And as Brooks mentioned in his comments earlier, what's happening with a lot of value-based payment programs is that there is an accountable provider, be that a primary care provider or a specialist, depending on the model and what's being addressed. But that accountable provider is now expected to influence the care across the continuum of care. So it is true that, like in a 90-day episode for a knee replacement, you know, not every one of those payments is going to be quote-unquote value-based. But when considered in that 90-day episode, the appropriateness of care, the cost of care, and the quality and the outcomes are all measured to determine whether or not the accountable provider might qualify for a bonus, or, you know, if it's an at-risk program, if they might have some sort of a penalty. So I would agree that, you know, the vast majority of payments are still being made on fee-for-service, but there's usually an attempt to reconcile the cost and quality of an episode or the care of a population of patients in a medical home or in an ACO. So I think it's a point well taken, but it's also, I think, reflects the nature of the programs that they're looking at value across that continuum of care instead of just a point in time. There's another question here. Were the numbers shown for Tennessee a roll-up of all the commercial plans as part of the multi-payer approach for Medicaid? And also, do all the models use a statewide cost target, or are there more specific targets, provider-specific targets? Sorry.
Yeah, so the results I was showing were Medicaid results. The implementation into commercial carriers is a bit behind just because of where their contracts were. So that's the only results we have now, even though commercial is now active in episodes as well. In terms of the, it was asking about statewide. Our thresholds for rewards and penalties are set statewide, and I think that was what the question was about. So we did look for the episodes program to see if there was variation in different regions for some of our episodes, and what we found was that there were providers who were able to have low-cost episodes, so below average in cost episodes, and high quality in each of the regions of the state. So, while if you look at the average, you might say, okay, well, on this episode, East Tennessee is more expensive than West Tennessee or vice versa. But if you look within that, you can see that it's possible to get a reward in any state, in any part of the state. So that's why we went with statewide.
All right, thanks. Another question I have is, you talked about kind of the nature of mandatory versus voluntary programs, and in your experience in Tennessee, what has the provider receptivity been, and how has that evolved over time throughout your program?
Yeah, so we have a mixture of voluntary and mandatory approaches. Our patient-centered medical home is a voluntary approach. Our episodes is a mandatory approach. Long-term services and supports has some mandatory approaches. And you do see different, you're kind of going for different changes depending on which approach you're taking. So, a voluntary approach is usually sort of an added investment into some early adopters or providers who are ready and really willing to make the change. A mandatory approach also engages those folks, but it's something to do when you see, as we do in our specialists in acute care, that there's really wide variation in cost and quality between providers that isn't explained by patients, it's not explained by geography. And so, in our episodes approach, for example, there's rewards and penalties, and so some providers are making changes to get more rewards, or else they're being rewarded for the kind of care that they provided for years and just sort of been, not really acknowledged until now, or not really paid for until now, the extra work that they're doing to go the extra mile. But it is also engaging those providers who are very high cost, and they're sort of in the top 10% of providers across the state. And in terms of the reception, I'd say, kind of like I said in my presentation, if you are doing a voluntary approach, you're really only talking to those folks who are kind of already ready to make a change and really want to, and that's great. And then with a mandatory approach, you're talking to those folks, of course, and kind of asking them, well, how have you been successful? What has allowed you to do so well? And that's a good conversation. But you're also talking to providers who have always been in fee-for-service. They've always just sort of ignored any potential change. And that's been a pretty successful approach, and all these other things have kind of blown over in the past. So it was not a bad strategy to just keep your fee-for-service, volume-based practice going. But I think, at some point, and I think that we've hit that point, we can't, as a country, continue to invest more and more money and not really see improvements in a lot of the outcomes and quality. So, we definitely had difficult conversations. We've had providers who have, and associations who have, gone to the legislature and either to talk about a specific aspect, so something really, kind of more detailed and technical, or to just say, we don't think that value-based payment should really be moving this fast in Tennessee at all. So, we've kind of seen it all.
All right, thanks. I think just one last question here that I've got, unless anybody wants to submit any more. What is the members' perspective of your program? Are they aware, and if so, what is their perspective on these programs so far?
Yeah, that's a good one. We've tried to, at various times, kind of gauge if the members have had much response to any of this. And really, it's interesting. Although people like some of the people on this call, certainly myself, spend all day thinking about these things, this is not what the patient really wants or cares about. What they want to know is, am I going to be cared for? And am I going to get good quality services? In commercial, many people like me have a high deductible health plan, so they also care about how much is this going to cost me. In Medicaid, most of the co-payments are really nominal, so that's not as much of a concern. But so the hope with a lot of these is that they're kind of behind the scenes, and if the member notices anything, they notice that, oh, my primary care doctor called me after I went to the emergency room and let me know that, I can come in and some additional care. I can, in the future, I don't have to go to the emergency room for this kind of service. Or, that when I got my joint replacement, they kept calling me to find out, how I was doing. They sent, a nurse home with me to make sure that I wasn't at risk for falling down. And that feels good. So really, these things are so technical, and the member, we hope that this just sets up the providers to be able to really invest in the things that the patients are kind of expecting anyway.
All right, thanks. We did have one more question come in here. And this is, I think, probably for both Lisa and Brooks. Given that many of the CMS programs include hospitals such as CJR, and Tennessee's programs are physician or specialist focused, is there a thought around getting hospitals involved with value-based payment, probably specifically at Tennessee, and then maybe Lisa, after Brooks, you could comment on the research that you did.
Yeah, so I disagree with CMS on this one. And maybe I'll back up a minute and say we have several episodes where we believe that the hospital is the provider who should be accountable, because in those episodes they are in the best position to influence the total cost and quality of that episode. So asthma exacerbation. This episode starts when somebody goes to the hospital or the emergency room. And so it really is the hospital that directs how the care is provided and, how that person is connected back to primary care. So we hold hospitals accountable for that episode. And a number of other emergency type episodes, the hospital is the accountable provider. But when we bring together a group of stakeholders for every episode that we design, and so we had a bunch of orthopedists and others around the table for the joint replacement episode when we said, who is in the best position to influence the joint replacement episode? They all said it's the orthopedist, and that's right. I mean, the orthopedist is the person who decides, what day you're going to get your surgery and where you're going to get your surgery. They'll tell you, I work with this facility. They do a good job, so we're going to book you there. And the orthopedist, is there before the surgery and after the surgery. So, we thought it made a lot of sense to go with the orthopedist. I think, and you can certainly ask CMS, but I think that the thought behind the CJR episode was just that for the purposes of administering this, it would be simpler to go with the hospitals, and so that's what they did. So anyway, I'm not opposed to value-based payment approaches that have hospitals accountable. I think it makes sense in several of them. I think that we went with what our expert providers told us in Tennessee, and I think it was the right one. I wish that CMS had done the same, and maybe that will change over time. We're certainly, we're both doing our approaches, so we'll kind of see what yields the most fruit. But Lisa, you can talk about, other states.
Yeah, I don't have too much to add to that. I mean, I do think it depends on the approach that you take. With episodes, that certainly makes sense. And it also has to do with your comment before, Brooks, about, what's simpler versus what's more fair. But I think like with ACOs, for example, in Massachusetts, the hospitals tend to be sort of the organizing structure of the ACO, and so, in that case, it makes maybe more sense to engage directly with the hospitals.
All right, well, thank you both very much for your comments today and for sharing your insights. It's been very enlightening. I'd like to thank everyone who attended today for your time this afternoon. Shortly, you'll be receiving an email containing today's slides and a link to the WebEx recording. Please feel free to share this information with others in your organization who may be interested. Again, thank you all. Enjoy the rest of your day. That concludes today's webinar.